Hi, my name is Brandon Calavoda. I'm a second year internal medicine resident at Advent Health Orlando. Today I will be presenting a case of a large recurrent mediastinal abscess presenting with cardiopulmonary collapse. Introduction. Mediastinal abscesses encompass several clinical challenges due to the broad differential and potential for life-threatening complications. Housing the heart, esophagus, trachea, and major vessels, even slight interruptions of this cavity can have devastating consequences. Case presentation. We had a 29-year-old female presenting with sudden onset dyspnea and cough with red sputum production for 3 days duration. Past medical history was significant for a dental abscess treated 10 years ago. 8 years ago, she had an episode of respiratory distress with a mediastinal abscess that was drained during a mediastinoscopy. Initial vital signs: heart rate 104, temperature 99.4 degrees Fahrenheit, respiratory rate 18, O2 saturation 98% on room air, blood pressure 111/75. Physical exam showed a well-developed female in mild respiratory distress with good oral hygiene without overt signs of oral infection. Cardiopulmonary exam was unremarkable. Labs showed a white blood cell count of 11,000, but the rest of the CBC and CMP were within normal limits. Hospital course. Patient was intubated shortly after the worsening of her respiratory distress. Further workup included CT chest and echo, which revealed large mediastinal mass concerning for abscess. Broad-spectrum antibiotics were started. EBUS with FNA revealed coagulase-negative staphylococcus. Mediastinoscopy with a drain was subsequently performed. Prevotella species was discovered from drainage cultures. 4 days following mediastinoscopy, the patient was successfully extubated. Her respiratory and cardiac status continued to improve. She was discharged home on augmentin, metronidazole, and linezolid, and remains asymptomatic with no recurrence of infection or respiratory distress in 8 weeks follow-up. At the top of the screen, we have her hospital course. In Figure 1A and 1B, we have both the coronal and sagittal sections from a CT angiography, which shows a large mediastinal abscess. Figure 2C and D, we have both a coronal and sagittal views, respectively, after the mediastinoscopy and drain placement was performed. Discussion. Mediastinal abscesses encompass many different etiologies. Presentations are broad, ranging from asymptomatic, found incidentally on imaging, to life-threatening cardiopulmonary collapse, as in our patient's case. Anterior masses encompass the 4 T's: thymoma, teratoma, thyroid goiter or neoplasm, and terrible lymphoma. Posterior masses, like the one presented in our case, may result from a neurogenic tumor, hiatal hernia, aortic aneurysm, embryologic cyst, or abscess. Initial surgical cultures from FNA collected during EBUS grew coagulase-negative staphylococcus, a type of staph commonly found as part of normal skin flora. The other organism isolated during mediastinoscopy was a Prevotella species, a genus of bacteria involving obligate anaerobic gram-negative bacteria that are commensal organisms of the oral cavity, gut, and vaginal mucosa. Mediastinal abscesses are usually the result of esophageal perforation, cardiac surgery, or pneumonia with local spread into the mediastinum, none of which apply to our patient. Occasionally, mediastinitis and abscess formation may result from caudal extension of a retropharyngeal or oral infection. Dental abscesses harboring these anaerobes can dissect into the posterior mediastinum through fascial planes of the prevertebral space. This seems to be the most reasonable explanation for the presence of Prevotella given her history of dental infection preceding the first mediastinoscopy. Additionally, endobronchial ultrasound with transbronchial needle aspiration is recognized as a mean of introducing infection into the mediastinum. It is unclear whether the coagulase-negative staphylococcus was inoculated into the mediastinum during the first mediastinoscopy or was a contaminant during the most recent EBUS with FNA. Another consideration is the possibility of a congenital mediastinal cyst that eventually became a host for the infection. The standard approach to treatment of a mediastinal abscess is emergent surgical drainage. In conclusion, mediastinal abscesses should be diagnosed promptly in order to initiate the appropriate therapy. Without surgical intervention, the patient would not have survived due to cardiopulmonary collapse.